Marcia Day Childress from the Center for Biomedical Ethics and Humanities, and we're happy to bring you these medical center hours every week. Our program today is called the Primary Care Physician, an Endangered Species. Is there a doctor in the house? Is there a primary care doctor in the house? Raise hands. Okay. Will we always see so many hands, or so few hands, in response to this second question? Or are we talking about a vanishing breed of MD? With aging of our nation's practicing physicians and the recent steep decline in medical graduates choosing careers in adult primary care, patients in the U.S. today are hard-pressed to find a primary care doctor. And the already impressive gap between supply and demand of primary care physicians is only going to widen once 30 million or more people gain access to health insurance through the Affordable Care Act. The urgent shortage of primary care doctors compounds our country's already significant healthcare challenges of access, delivery, and cost. In an era when all of healthcare is undergoing potentially transformative change, what will be the role of primary care doctors? For patients, what will be the value added of having a primary care MD? What roles will other primary providers play, including physician assistants and nurse practitioners? Is the primary care physician an endangered species or a key participant in a newly configured primary care team? How should health professions, educators, and schools devise, model, deploy, and teach new ways of delivering primary care that are team-based, interprofessionally collaborative, effective, and satisfying to patients and practitioners alike? To think about these questions, we're delighted to welcome to UVA family physician and medical journalist Susan Okie from Bethesda, Maryland. In May of this year, Dr. Okie wrote a powerful perspective essay for the New England Journal of Medicine that explores the prospects ahead for the primary care doctor. Drawing on her research and interviews done for that article, she'll talk with us today about the evolving primary care physician and prospects for the future. Following Dr. Okie's presentation, we'll hear briefly from two of UVA's primary care physicians. Dr. Sean Reed, a family doctor and teacher here at UVA, seated in the middle, and Justin Mutter, a fourth-year medical student planning a primary care career. You'll find brief biographical sketches of all three speakers in your handout. The UVA School of Medicine's Generalist Scholars Program is our partner today for this Medical Center Hour, which is part of the observance at UVA of Primary Care Week. The apples you've received at the door, more to keep health in mind than to keep doctors away, are courtesy of the Generalist Scholars. And we'd like to welcome Susan Okie and start this conversation.
Hi everybody. You can hear me if I stand straight up this far from the mic, I hope. It's a pleasure to be here, and I'm a little intimidated to be in an amphitheater that looks like the ones where I had my medical school lectures so many years ago. I want to warn you, I'm a dinosaur. I don't have very many slides. I have 3 slides, and they all were sent to me by the kind editorial assistant at the New England Journal, because I really don't know how to do PowerPoint. And you'll forgive me if I repeat some of the questions that Marcia already read to you in her introduction, because she had me send her a teaser, and then I didn't realize that some of what was in the teaser was also in my speech, so I just have to repeat myself a little bit. But as you heard, we have an aging primary care physician workforce in our country, and we have at least a declining number of U.S. medical students choosing the care of adults, primary care of adults, although different numbers depending on who you talk to in the different specialties, family practice versus internal medicine, and of course pediatrics, primary care as well. But many adults in the United States in particular are already having a very hard time finding a primary care doctor. and certainly true in Washington, where I come from. And the gap between supply and demand has been projected to widen greatly in the next few years, partly because we can expect more than 30 million people who are currently uninsured to gain insurance under the Affordable Care Act, which I hope will survive and thrive. And so the scarcity of primary care physicians in many places is sparking debate over how many and what kinds of primary care doctors we need, doctors and other providers we need, to care for U.S. patients, and how we can meet the healthcare needs of rural communities and other underserved populations where lack of access has been a neglected issue for decades. Nurse practitioners and physician's assistants are being trained and deployed in ever larger numbers to deliver primary care, and retail clinics and urgent care centers are springing up to help fill the need. Spurred by new financial incentives for becoming a patient-centered medical home, health systems and private practices are consolidating or enlarging in order to be able to gain more staff, and are increasingly emphasizing team care. Meanwhile, electronic health records, computers, and new technology are radically transforming the workday and the workplace of physicians and other healthcare professionals, often cutting into the time that they can spend on face-to-face interactions with patients. So what will be the role of primary care doctors in this new and rapidly changing landscape? And as Marcia asked in her lead-in, what is the value added of having a primary care physician? How can we preserve the human side of primary care medicine while also managing this new technology? How can we model new ways of delivering primary care for our students and for our residents, and create training programs that both inspire and empower physicians and other professionals to practice excellent primary care on collaborative teams? How should medical education, training programs, and financing of medical care change to address our country's healthcare needs? I don't have answers to these questions. I wish I did, but I am hoping we'll talk about them today, and I'm looking forward to the responses of my colleagues. And as you heard, I wrote a perspective article that I proposed to the New England Journal earlier this year when they were planning, or maybe it was late last year, when they were planning the lineup of perspective articles that they wanted to run during 2012, which is their 200th year anniversary. And many of these were looking back at the history of medicine, but I wanted to look ahead at the future of primary care as best I could. And they were supportive of that idea, they liked it. So the article came out last May, and as I understand, although I don't always get to see all the feedback, has sparked a fair amount of discussion in primary care circles. I am not a health policy expert. I approached this topic as a family practice physician and as a longtime medical journalist. I was with the Washington Post for about 20 years as a reporter and editor. So I read some of the literature in the primary care workforce and on doctors' satisfaction with their careers, and I interviewed people who I was able to identify as keen observers and original thinkers about the future of primary care. My thoughts are also influenced by my own ongoing experience as a volunteer doctor working with nurse practitioners and physician assistants to care for uninsured adults at a van-based clinic run by Mobile Medical Care, a nonprofit organization in Montgomery County, Maryland, that provides primary care to low-income adult residents of that county, uninsured residents. So first of all, is there really a doctor shortage? The New York Times seems to think so. Doctor shortage likely to worsen with health law ran the headline of a July 28th story. It cites estimates by the American Association of Medical Colleges that the nation's doctor shortage will amount to 63,000 doctors by 2015 and more than 100,000 by 2025. But the AAMC's estimates do not account for the fact that primary care is being provided not just by doctors but by other professionals, especially nurse practitioners. They're based also on traditional ratios of physicians to population, which do not take those other professionals into account and also don't make adjustments for other innovations like team-based care. We know from Barbara Starfield's research that health systems that provide primary care which is defined as care that features long-term, person-focused, comprehensive care for most health needs and coordinates treatment when it must be sought elsewhere, that this kind of primary care is associated with better health outcomes for patients. But in the United States, according to the Dartmouth Atlas, which compares data on different geographic areas of our country, there is no relationship between the supply of physicians and access to primary care. Furthermore, within the United States, those areas that have the highest physician-patient ratios or even the greatest supply of primary care physicians are not necessarily associated with the best patient outcomes. Workforce supply, physician workforce supply, is associated in the United States with the amount of health care that people receive, but not with whether that care is warranted. So it appears that creating a system that delivers effective primary care that really does improve outcomes is a lot more complicated than we might think. If we look just at the U.S. workforce, and here I have to change the slide, a report issued in July 2011 by the Robert Wood Johnson Foundation concluded, surprisingly, that, quote, data do not support the suggestion that the United States is currently experiencing or facing an imminent shortage of primary care providers. The numbers of physicians, nurse practitioners, and physician's assistants have grown in recent years relative to the general population. You can see from this slide that physicians make up about 3/4 of that workforce, and nurse practitioners and physician's assistants make up the other quarter. The number of primary care physicians per 100,000 population actually increased modestly by about 12% during the decade from 1995 to 2005, while physicians in other specialties increased by only about 5%. But nurse practitioners are by far the fastest growing slice of this pie. Their numbers grew by more than 9% per year relative to the population between 2000 and 2005. And most nurse practitioners do practice primary care as opposed to most PAs who currently tend to work more often in other settings. So in the mix of who will be delivering primary care to U.S. patients in the future, we can see that the mix is clearly shifting, and the demand for primary care is expected to outstrip the supply of primary care doctors. So from those trends, it appears evident that in the future, more and more patients will be seeing nurse practitioners for some or most of their primary care encounters. The other major finding of the Robert Wood Johnson Foundation report is that there is profound maldistribution of providers, and this has been a chronic problem in our country. Healthcare providers tend to congregate in urban and suburban areas, as I'm sure you know. Many rural communities and inner city neighborhoods have great difficulty attracting physicians to practice, and this gap in access continues to grow. This has been true even though the supply of general pediatricians and family practitioners increased, pediatricians by 51% and family practitioners by 35% in the decade ending in 2006. Dr. Warren Newton, president of the American Board of Family Medicine, told me that pediatricians remain heavily concentrated in urban and suburban areas, and that family practitioners provide 50% of outpatient visits for children in rural areas. We do know that doctors who are women or members of traditionally underrepresented minorities are more likely than white males to practice in underserved areas, and that we depend on foreign-trained physicians to fill part of the gap in primary care access. They make up close to 1/4 of our current primary care physician workforce. Dr. George Thibault, president of the Macy Foundation, which is dedicated to advancing the education and training of health professionals, is the son of a rural Maine GP and has had a long career in medical education. Among the people I interviewed for my article, Dr. Thibault stood out as the person with the most far-thinking radical ideas about how to redesign the teaching and training of doctors to better suit our country's needs. Dr. Thibault believes that we can't expect to solve our primary care problems simply by increasing enrollment in U.S. medical schools, which I think is a major solution proposed by the AAMC. We need instead to recruit more minority students and more students from rural areas, and we need to educate and train our primary care residents and students in ways that empower them to deliver high-quality primary care in the settings where they plan to practice. He argues in favor of loosening the traditional and financial bonds that tie our training programs so tightly to hospitals, and, quote, using the Kaisers and the health centers of the world for training more than we are now. He also believes that we should tailor training more individually for different students and residents to each student's eventual career goals. Quote, somebody who wants a rural setting needs to have experiences that prepare him for that, not working in a big inner city clinic with 8 other professionals, he said. I would add that if we are serious about attracting more doctors into primary care, we need to make efforts to narrow the huge disparities in reimbursement between primary care and specialty care physicians, and to offer other financial incentives. Research shows that loan repayment programs and scholarships provided by the National Health Service Corps and by state programs do result in doctors practicing in needy areas, and many stay on in such practices after their period of obligation ends. Thibault suggests that we could also follow Canada's example and make the number of slots available nationally for training doctors in various specialties much more closely correspond to our country's projected needs. So how have the demands on primary care doctors changed? Are we facing record levels of physician burnout? Another New York Times article claimed that we are. If you look at the longitudinal big picture, national surveys of physicians in all specialties suggest that most doctors remain satisfied with their work. More than 80% were somewhat or very satisfied in 2004-2005. The most recent data available from the Center for Studying Health System Change in Washington, which performs these periodic surveys. The percentage of doctors who were satisfied had not changed in a decade, and the fraction who are somewhat or highly dissatisfied hasn't budged either. In 2008, it was about 15%. On the other hand, a study just out last month in the Archives of Internal Medicine, which was picked up in the New York Times article that I mentioned, reported that U.S. physicians are more likely than other professionals or working adults to have symptoms of burnout. 38% of roughly 7,000 doctors surveyed were reported to suffer from it, compared to 28% of the non-physician sample that they took for a comparison, which did include other kinds of professionals. The highest rates of burnout were reported by physicians in family medicine, general internal medicine, and emergency medicine, specialties that are often the first points of contact for patients seeking care. I should note, however, that this survey had a low return rate. Only 26% of recipients responded to it, so the results are quite likely subject to selection bias. And since it's the first survey of its kind, as far as I know, and as was claimed by the New York Times, it really doesn't tell us whether things are worse now than they were in the past. We do know that in recent years, the pressure on doctors and other providers to fulfill multiple expectations during a patient visit has increased, with new emphasis placed on guidelines and quality measures. That health professionals are often expected to enter data into electronic records before, during, and after each visit, and that providers are under constant pressure to move quickly, stay on schedule, and hit targets for numbers of encounters in a shift or workday. These demands add up to a high-stress work environment. Concerned that primary care doctors were burning out and becoming overwhelmed, physicians Christine Sinsky and Thomas Bodenheimer recently visited 23 primary care practices in a project sponsored by the American Board of Internal Medicine Foundation, looking for ways to help doctors sustain joy in practice. In spite of the benefits of electronic health records, Sinsky calls the move to EHRs, quote, an enormously disruptive innovation. She told me, I think 2/3 of many physicians' days are spent on documentation, administrative tasks, paperwork completion, rote inbox management, data gathering, and data entry. With laptop computers, many providers end up taking some of this work home at night. This problem gets to the whole question of how you create a medical team that shares the burden of clerical work and data entry, allowing all members to, quote, practice at the top of their licenses, a phrase that I heard repeatedly during my reporting. In some of the most innovative practices they saw, Sinsky and Bodenheimer observed collaborative models in which a nurse or a medical assistant accompanied the physician as a scribe, entering the findings and the treatment plan into the computer, and later printing out prescriptions and patient instructions. Like most primary care doctors, Sinsky says that her emotional connections with patients are the most rewarding aspect of her work. She says her survival strategy in her own practice has been to try to figure out how to maximize the time she spends on those connections and how to minimize time spent on things that don't create that sense of value for her and for her patients. Sinsky works in a teamlet with a medical assistant and a nurse, and she delegates responsibility for routine preventive checks like diabetic foot exams and for things like vaccinations, as well as she delegates a lot of data entry. The nurse is a key clinical partner. She sees each patient before Sinsky does, knows the patients well, fills Sinsky in on active emotional and medical issues, and takes care of most of the care coordination that goes on between visits. Abraham Verghese is a professor of medicine at Stanford University and the acclaimed author of the novel Cutting for Stone and several nonfiction books, including My Own Country, a moving memoir of being a young AIDS physician in rural Tennessee during the early years of the epidemic. Verghese believes that the history and physical are not just a data-gathering exercise. He says that when our patients tell us intimate things about their lives, then undress and allow touch during the physical examination, a sacred bond is created. Quote, "We are not robots, we are embodied creatures," he told me. We have certain spiritual and physical needs, and I think medicine has forgotten about the spiritual aspect. He believes that the physical exam is not only a vital skill, but a ritual with therapeutic value. And he maintains U.S. students and residents are becoming less skilled at performing it today than they were a generation ago. He attributes that loss of clinical skills to the increased focus on technology in our hospitals and the resulting decline in bedside teaching by attending physicians during the clinical years of medical school and during residency. Verghese maintains that the OSCE clinical skills exam required of graduating medical students and involving a standardized interaction with an actor patient does not really test clinical skills. He would like to see it replaced with what he calls a high-stakes clinical examination like those in Britain and Canada. I can't tell you any more about that. I wish I could have seen one happen. Expertise in the physical exam, according to Verghese, should be part of the value added that you get from a physician. He said, we should be at least as good as the PA or the nurse practitioner, or we should be better. We bring more to the ritual just by the privileged position that society gives us. Beyond these basic diagnostic skills, there is evidence suggesting that primary care doctors' scope of practice is narrowing compared with what it was in the recent past. As we know, hospitalists now are in charge of caring for inpatients in many hospitals, and it is becoming rarer and rarer for general internists and family practitioners, and I'm told also for pediatricians, to manage patients from their practices during hospitalizations. In 2006, almost half of hospitals and 84% of teaching hospitals had at least 3 hospitalists, according to a study by Akuo in the New England Journal. The American Board of Family Medicine regularly surveys the nation's 70,000 board-certified family physicians about the scope of their practices and shared some striking findings last year. 80 to 90% of family physicians now report spending no time on preoperative, postoperative, or maternity care. 60% said they spent no time on office surgery. 55% said they spent no time on mental health care. And 25% said they did not see children. Dr. Newton, the ABFM president, told me that some of this narrowing of scope probably reflects the fact that family physicians are increasingly being employed by large health systems, where they're generally being asked to see adults because there's a shortage of general internists but not of pediatricians. In rural areas, family practitioners are more likely to be doing something closer to the full spectrum of what they were trained to do, including the primary care of both adults and children. But in cities and suburbs, it seems they're being deployed to fill the gaps created by a lack of other specialists and a lack of general internists. I don't have comparable data for internal medicine about narrowing of scope of practice, but Sinsky told me her impression within her own practice and at the 23 practices she visited is that general internists are more often referring problems to specialists that they would have treated themselves in the past. She said she tries to maintain breadth and variety by learning to do procedures and by cultivating relationships with specialists so that she can call them for advice, allowing her to manage certain conditions herself instead of referring them out. As a reporter writing about primary care, I've seen effective team-based care in action, most prominently in Sinsky's offices in Dubuque, Iowa, and during a couple of days I spent at Kaiser Permanente medical locations in Denver, Colorado. I was impressed by what I saw. But as a volunteer physician working in a van-based safety net clinic for uninsured adults, I've come to realize that, like most health professionals, I wasn't ever taught how to practice outpatient team-based medical care, and it doesn't necessarily come naturally. For the last 7 years, I've been seeing patients in tandem with nurse practitioners and more recently with a physician's assistant. Most of the time, we're like 2-year-olds engaging in parallel play in a sandbox. We're struggling to get through the day's patients, and we rarely have time to talk about a case, much less about how the clinic is functioning. There's no fail-safe way for me to make sure that my colleagues know when I'm worried about a specific patient, since I'm only there once a week, so that if someone else sees him or her when I'm not there, the provider will be aware of all my concerns. The quality of our team's communication varies. One nurse practitioner functioned as my partner. We shared information on difficult patients, and she would call me in when she was uncertain about a diagnosis. With some others, I'm seldom or never consulted, although it stands to reason that I should be utilized when a patient has multiple problems or when there's a question about the diagnosis or the appropriate treatment. Our organization runs multiple clinics, and it has something like 100 physician providers and a staff of several dozen, and it struggles with excessive ordering of tests like MRIs, abdominal scans, and low back imaging. I think that in part this problem may reflect lack of confidence or thoroughness on the part of both nurse practitioners and volunteer physicians in their history and physical skills. Many of the organization's doctors, like me, have worked primarily in non-clinical jobs throughout the Washington area at the NIH, the FDA, different agencies, and are volunteering in order to keep their clinical skills up and to be of service. We go to conferences and receive memos about reducing unnecessary tests. But as basic as it sounds, I think many primary care providers in the community, physician and non-physician alike, could probably benefit from regular review of key aspects of the history and physical that relate to specific medical problems. And all of us could benefit from learning more about how to communicate across our professions, for example, between nurse practitioners and physicians. Dr. Doug Kelling, a North Carolina general internist who single-handedly transformed his practice to a team-based model in the mid-1990s, says the biggest barrier to effective team building that most residency training has is that it's, quote, training to be the Lone Ranger, where one person goes in is supposed to be all things to all people. Kelling and 2 other doctors in his practice currently work with 6 physician's assistants, 2 doctors of pharmacy, a caseworker, a discharge planner, registered nurses, and other staff. He says he wants to make medical care more like NASCAR, with the doctor as the driver and other staff members responsible for the fuel or the tires. He says that as doctors, we can be most effective by letting other people do the things that they can do better than we can. By following treatment protocols, he says, physician's assistants or nurse practitioners can treat 98 to 99% of the problems that present in his practice. That frees me up to do what I enjoy most, he told me, to take care of patients where there's a gray area, where there's no best way to handle it. That, I think, is probably what people do mean when they talk about creating a team where everybody's practicing at the top of their licenses. In a number of innovative family practice and general internal medicine residencies, trainees are being taught how to work this way. There's also a brand new focus around the country on interprofessional education. For instance, programs are being piloted to educate medical students, nursing students, and pharmacy students together some of the time. So having them work as teams to solve problems in the hope of bridging the distinct professional cultures that in the past have too often gotten in the way of collaboration and communication in the hospital or the clinic. I think that these developments have the potential for making primary care both better for patients and more satisfying for all health professionals. But can we make it happen? Can we put it into practice? Doing so will require breaking down cultural and political barriers between medical specialties, between the medical and nursing professions, as well as reforming the way medical care is reimbursed, so that covering the cost of team care becomes economically feasible for practices that aren't part of a giant health system. Right now, a Kaiser or a Geisinger or a Mayo can do it, but a newly minted family practitioner or internist practicing small-town medicine in Colorado or Alabama can't afford to. I'd like to think that primary care physicians will survive as a species and become adept at working with other professionals in teams, rather than becoming extinct or surviving only in concierge practices for the wealthy. But achieving the political and systemic changes that it would be necessary to make in order for that to happen is going to make passing the Affordable Care Act look easy. Thank you.
First of all, thank you, Marcia, for the invitation to be here today. Dr. Okie's title of her article touched on the concept that in order to remain, you have to remain innovative to avoid extinction. And Blockbuster and Netflix have taught us and underscored this principle in spades. And I would argue that it's important for us to take heed of their experience as we move forward in primary care. And I'd like to introduce three themes: redundancy, relevancy, and reconstruction, that help frame my concept of where we're going in primary care. There's no shortcut and there's no substitution for the knowledge and clinical experience of a physician. I think some of you would join me in saying that Dr. Kelling in Dr. Okie's article overreached a bit by saying that 99% of his patients, adult patients, could be cared for efficiently by his nurse practitioners and PAs by doing, quote unquote, what is obvious. Now, I'm the first to say that the care of patients is a team sport. I recognize that the team-based care of the future has to include all team members. And by that I mean that each member of the team has their own specific skill set. And matching that skill set, that right team member, with the right patient, specifically paying attention to the undifferentiated patient, is an important skill. Ironically, I guess what I'm saying is there needs to be some specialization within the primary care team. Reconstruction. If you've been reading the papers, you know that the pharmacists are aggressively lobbying to expand their ability to provide immunizations to our patients. You know that Walmart and others continue to find ways to deliver health care in their stores, in their retail clinics. You know that there are MedExpresses popping up on every corner, literally dozens in Virginia and around the country. So what does that mean? For the first time in history, Anthem, lured by new CMS G codes, which offer a handsome price or reimbursement for the care of patients recently discharged from the hospital, they will, for the first time in their history, and to my knowledge of any payer's history, employ physicians and other healthcare professionals to deliver care in, quote, special centers. I ask you, I let you think about what that will do to the viability of the patient-centered medical home. If you siphon off the top some of the most lucrative services, and you further fragment the care of those patients, what impact will that have? The promise is to coordinate this care in these special centers with primary care physicians. But in the world I live in, the reality is, despite best intentions, the new EMR at HealthSouth doesn't in any meaningful way coordinate or sync with our epic care. And as we know, that's a challenge. The real zinger is that Anthem's actually advertising these new programs with comments like this: don't feel pressured at your primary care physician's office. It's not fair to be rushed in and out in 15 minutes. Come see us for comprehensive care. We'll teach you about Nifty at 50 and some other important things that will help you in your life. I ask you, Anthem, where does that time pressure come from? Relevancy. So where is a primary care clinician supposed to, how are we supposed to remain relevant? It seems obvious, but I would suggest that starting with quality is a good place to begin, especially as our new system gears up to, for the first time in literally a century or better, be able to identify quality. But that's not enough. That's a starting point. The cost equation will continue to be important. And I will tell you that the cost data is robust. Here's some data. No PCP means doubling ER utilization rates. This is specifically for low economic patients. Adding one family physician adds nearly $1 million in revenue to that community. That's $46 billion across the United States. That does not include the money that this institution, this hospital would gain, or nursing homes in the area. You can see the American Medical Association joined forces with a nonprofit in 2011. They wanted to look at the economic input on the economies for outpatient-based clinics, and you can see that the actual subspecialty of family medicine had the largest footprint, and you can see the data there. And lastly, adding just one FP per 1,000 people in a community lowers the admission rate for these three disease entities respectively. This data is important. It's important to our patients, it's important to our politicians and our government agencies, and it's important to payers or insurers. So in conclusion, there are some significant threats to healthcare, not the least of which is profiteering, the continued segmentation of care, and the poor coordination of care. Dr. Tugawande, who wrote in his new article, Big Med, he talked about the chain restaurant industry, and he talked about guest forecasting, a software program that allows the Cheesecake Factory to actually predict what you're going to order in what month of what year. It's amazing. Continuity is the precious commodity that we as physicians and clinicians hold. Continuity of care provides the knowledge not only that allows us to say what is the best treatment for a particular patient, but perhaps equally important, where might they fail? Where do they need our support? And it might not be a drug, it might be a ride. At the Center for Medicare and Medicaid Services for Innovation, Dr. Gilfillan and his colleagues are quite simply at a point where they're trying to dissect from the patient-centered medical home and team-based care, what are the components of that that work best? I would argue just this, that as we move forward with the reconstruction of healthcare, we must ensure that it ensures first and foremost a model that delivers high-quality care, that minimizes the redundancy in our team and takes advantages of the teamwork that Dr. Okie and others have talked about. It takes advantage of the health benefits, of which I've shared some, that primary care offers, and it underscores the reality that our continuity is the precious resource that we offer our patients and the healthcare system. Thank you.
Thanks to GSPers, the Generalist Scholar Program, to Professor Childress for having me today. It's a real privilege to be a part of this conversation. It's a privilege to get to chat with Dr. Okie and Reed. The tremendously exciting future of primary care is, of course, something that any of us here could probably talk about for hours. I have just a few minutes. And in considering what to say today, I ask myself, if there's just one thing that we must never forget, that we must constantly hold in the front of our minds as we each endeavor to transform primary care services, what would that be? I regret to say that one thing did not immediately come to mind. Should it be the complex ins and outs of practice redesign? Should it be team-based care, the need for payment reform, a renewed focus on the social determinants of health? I was at a loss trying to adjudicate between the many competing visions for the primary care of the future. So, being the total dork that I am, I turned to poetry for a little bit of inspiration. Specifically to the poetry of the Irish writer Evan Boland, one of my all-time favorites. As I flipped through her collected poems, I came upon a poem entitled I Am From Ireland. In it, Boland assumes the role of a young woman immigrating to the United States, seeking to escape the crushing poverty of Ireland in the 19th century. And the stanza that really caught my attention was the final one of the poem, and it reads as follows. A new language is a kind of scar, and heals after a while into a passable imitation of what went before. A scar. Not exactly an uplifting image with which to end a poem. But I think what Boland is trying to remind us is that the journey, the healing process, is fraught with danger. As any health professional knows well, wounds can do all sorts of things besides heal. And even when they do heal, there is the scar. The scar is a very paradoxical thing. On the one hand, it's a physical testament to healing, to physiologic success. But on the other hand, it is a reminder of the wound that once was, and that perhaps is still a part of us. To journey is not just to move from A to B, from the old to the new, or from hardship to a land of plenty. It is to struggle toward a new horizon. And as 19th century Irish immigrants knew all too well, the passage itself is precarious. As we've heard today, primary care is in the midst of such a journey. There are many, many reasons to leave the worst of our old systems behind and to head toward better promises for the future. Like a wound healing toward a scar, however, success is not a given. It will take all of our attention and the best of our care. What's more, in these relatively uncharted waters, we must neither forget the place that we've left, nor the destination toward which we are heading. But we also need a compass, an organizing principle, to make sure we stay on course. Which brings me back to that one thing. What is that one thing that we should hold in the front of our minds as we work toward primary care transformation? It is, of course, our patients. While this may seem obvious, unfortunately our track record for assuring that medical innovation serves patients first is not particularly good. If it were, we wouldn't be having this conversation today. In the midst of the excitement of new models and new directions in primary care, it is easy to forget that our patients are passengers with us on this journey. Innovation can be as disruptive for patients as it is for providers, for administrators and health systems. There are plenty of examples of how primary care transformation too often doesn't consider the patient's view as a guide for change. Technological innovation, which Dr. Okie mentioned, is perhaps the most well-known and widely experienced of these examples. There is much to applaud in the development of health information technology and many potential benefits for patients and providers alike. Yet, as Dr. Okie mentioned, we run the very real risk of organizing patient care around the computer rather than around the patient, him or herself. And as Abraham Verghese has compellingly described, visitors to our wards and clinics across America might well come to believe that we are treating eye patients rather than physical human beings. But there are other, perhaps more subtle examples of how innovation can neglect the patient's viewpoint. As primary care embraces the concept of value-based health services, the metric of quality divided by cost is rightly replacing the old metric of service rendered divided by cost. But quality is not the same thing as a positive health outcome. Good care does not guarantee good health. Patients do care whether or not they are provided with evidence-based services. But much more than that, they care whether they become healthy again and stay healthy. Perhaps then we need to reconfigure our metric to define value as outcomes divided by costs. Or consider what is arguably the most important innovation in primary care today, the patient-centered medical home. There is much in the PCMH model that is resolutely patient-centered. Based on widely recognized guidelines, however, it would be entirely possible to become a fully qualified PCMH without providers having to step outside their clinics and into their patients' communities. The overwhelming focus of the PCMH is on innovations in the medical neighborhood at the expense of focusing on our patients' neighborhoods. Keeping the patient's view front and center might remind us that the vast majority of health and disease happens where patients spend the vast majority of their time, at home, at work, and in their communities. So in Evan Boland's words, primary care today is developing a new language. We are patching up old wounds, working toward a kind of scar. It is no easy task, and the journey is at once exciting and daunting. As we struggle toward this new horizon, we must always remember that we are traveling alongside our patients. Their needs are our compass. They are depending on us to stay on course.
Thank you. I think you've heard from these three presentations today that, at least in our neighborhood, primary care is in very good hands. And it has a very promising future. We'd like now to involve you in the conversation. Your comments and questions may be directed to any or all of our speakers. And, in a sense, we have yet another newer generation well represented in the audience, those of you who will be joining or who have already joined this journey that primary care is on. So when you offer your question or comment, please also identify yourself. And who would like to go first? Where are you? I'm sorry, where is the question?
Over here.
Okay, I'll be right there.
Engelhart, a family physician here in town for 23 years. And I'm proud to say I'm one of the 47% of the population of this country that Romney thinks doesn't belong. I say that because in 1978, I accepted a scholarship from National Service Corps to go through my osteopathic medical training for free and then serve for 4 years in an underserved area. And I bring this up to say that I think that unfortunately money is perhaps going to be speaking louder and louder to our medical school students, because the financial reimbursement for family physicians is far lower than what you might get if you follow a specialty. So the sad thing, and I haven't heard it discussed yet, perhaps we can talk about it a bit, is how does the government or anybody else get involved in raising either the salaries of primary care physicians or paying for medical care like I had.
I think that it would require a wholesale reform of the reimbursal system, which I think would probably, the last time that was done was when the relative value scale was put into place, and it was supposed to be a move towards equalizing payments somewhat, but it wasn't very effective in that regard. And I think we would have to go through another process more radical than that, probably by a task force or a group of experts, and then passed as a piece of legislation. It's, it's really hard to imagine how that can happen, but that's what needs to happen if we were serious about attracting more graduates into primary care. The other thing is increasing the National Health Service Corps, other programs to try to provide other kinds of financial incentives for going into primary care, loan forgiveness and so on. And as I mentioned in the talk, there is evidence that that works. But I agree with you that there needs to be an effort towards leveling the playing field so that it's not so attractive to go into specialties that are 4 times as much. And we've seen how hard it was to pass the Affordable Care Act. After this doctor shortage article came out in the New York Times, the economist Uwe Reinhardt from Princeton has been blogging, and one of his points about primary care and the shortage is that our country gets what it pays for, that we haven't made this a financial priority.
Either one of the others care to comment?
Just quickly, I think some of the innovations in practice design have also resulted in some of the demonstration projects have resulted in 20 to 30% increases in remuneration for physicians and everyone on down the line that's on the team. So even just by restructuring the way we're delivering care, there's value. And that has been obviously shared amongst those that are paying for that, but also with those that are providing that on the project.
Question?
Nellie Carter. I'm a first-year med student. How do you think that the this move towards team-based team medical practice, where you have a lot more people involved and having to have a bigger office, basically, is going to affect the shortage in rural communities, where it's hard to even kind of support financially one physician, and then you're talking about supporting fancy medical records and lots more people in the office to provide this kind of holistic care.
So, can you turn very mic, please? For technology.
Can you just tap on your mic for me?
Tap on
Okay, so just press and hold the top.
that on? Yeah. So, I mean, in terms of rural health, I think it's a really interesting question. In particular, it's one of my interests. I think that a large portion of the ACA, for example, was not designed with rural communities and rural hospitals, rural clinics in mind. And I think that could end up being a real challenge for us in the future. I think what you're alluding to is that there are quite a few and quite a large amount of capitalization costs to do this kind of practice redesign at the clinical level. And that money just simply doesn't exist for many small providers, which is why, as Dr. Okie mentioned, we're seeing this transition where smaller practices, including in rural areas like Southwest Virginia, are being bought up by some of the larger hospital-based systems in the region. I think from my perspective, what it's going to take is thinking about healthcare not just nationally, but thinking about it locally and regionally. And I think that's something that, unfortunately, we do a pretty poor job of, with at the government level. And having sort of challenge grants from governmental bodies that then are available to smaller providers, medium-sized providers, where they can overcome some of those upfront costs and make the changes that they want to.
Gordon Putnam, I'm the chaplain in the Cancer Center. Oh, you wanted to say something?
I just was going to add that in North Carolina, I think they've experimented with some projects where there's been a care coordinator who's been shared among a number of practices. So one thing you can do in rural areas when you're adding ancillary staff is to share the cost among several practices and still manage to do some of the team-based care that way in the meantime. Yeah.
I was trying to think of the relationship I have with my PCP. I'm healthy. I see him once a year for a physical. My wife is healthy, sees a nurse practitioner for some of her care. It seems to me it's relationship more than expertise in primary care or any care. And that's what I see is the faith that a patient has in their provider, whether it be doctor, nurse, chaplain, whatever it might be. How does that fit into this whole process? The relationship rather than the money or who's doing the care. I'm not sure a physician needs to do a physical on me. I think a nurse practitioner, physician assistant. So I don't know, what is that relationship and how does that work in this whole process of looking at primary care?
I think that's a great question. You speak to the continuum of care. So from the worried well to the truly well to the truly sick. And that relationship is important to all those patients. It's important to you when you come in healthy, and perhaps when you're feeling quite ill, it's important to you to see that person, that you have that trust in that relationship in. I think that the continuity of expertise also transcends that same spectrum. So at a certain point, you'll need a certain expertise, and at many points you won't. And so the trick of the team will be to try to, as I said, balance that so that you're seeing the right member of your team at the right time. And I think that there's an emotional, not just a get well thing, but there's something incredibly powerful about being with somebody that you know when you're sick. And it might not be the person, but it might at least be that team.
I agree with that. I think that what I saw, for instance, at Kaiser was that a physician and a nurse practitioner would work as partners on one team. So the patients who belonged to that team would sometimes see the doctor, would sometimes see the nurse practitioner, and would get to know both of them. So rather than having one relationship, they basically had two relationships. But the doctor and the nurse practitioner functioned as partners, and the communication was excellent. So they were able to pretty much cooperatively manage patients. And similarly with Dr. Sinski's practice, her primary nurses got to know the patients as well as she did, so that there were two relationships going on. And when the nurse was the one to call with test results or to discuss certain things in between visits, that worked out fine. But I agree that it's the sort of continuity of care and the repeated contact with the same person that really matters. At the same time, you know, you would want to have good enough communication so that if your wife sees the nurse practitioner and there's some issue with what's wrong, the nurse practitioner would know when it was time to talk to the physician or to refer your wife on for a test or for, you know, a consult or something.
Hi, my name is Supriya, and I'm a current applicant to osteopathic medical schools. And I just had a question. I think all of you in some way touched on specialization within the primary care practice and specific roles for nurse practitioners and physicians. And I just, Susan, I think that you talked a little bit about it already, but I wanted to know specifically in an ideal world what that specialized team would look like.
Well, I think, for example, having somebody who is adept at doing health education is a good thing to have on the team. And I don't think doctors are always the best at that. If I have a patient with diabetes, I would love to have a nurse or someone else who's trained as a health educator who can really go through the basics of diabetes with that patient. And I think, you know, at a Kaiser, there is somebody backstopping the doctor, looking at the combination of drugs that a patient is on, sometimes helping manage the best choices in terms of combination of antihypertensives. Having resources like that, somebody who's really just looking at the drugs, or somebody who's really looking at the education piece, or someone who can sit down with a patient and help them apply to the programs that they need to apply to get their medications for free if they can't afford them. Those kinds of services are really sort of central to primary care, and as a physician where you're having to see people on a schedule, you don't have time to render them all yourself. So I don't think it matters so much the title or the degree of the person, but you have to have a way of building a team that can provide all these different services. I don't know which ones should be done by a nurse practitioner versus a nurse, and it depends on what area of the country. Places that, like in Iowa, Dr. Sinski hires RNs. People on the East Coast say, that's crazy, we could never afford to hire RNs in our practice. But medical assistants can also do a lot of things if you train them to do them. So it really depends upon where you are and personnel that are available, I think.
Hi, everybody. My name is Carolyn Englehart, and I teach health policy here. You know, I just wonder if each of you might comment briefly. I know we're out of time. What I've been hearing is, you know, coordination is key, and relationships with patients are really important. And yet the Commonwealth Fund out of New York does these surveys every year where they ask all sorts of, they measure across different developed countries, healthcare systems, looking at access, quality, and cost. And under the access piece, we, the U.S., routinely fall at the bottom when it comes to availability of appointments after hours, on weekends. So it sounds like we sort of have this duality here. We want to practice coordination and patient-centered care, but we're really not available to patients at a lot of the time when we should be. And I know PCPs feel like they're overworked and underpaid and all of that, but how do we compensate? I mean, Sean, if we don't want the MedExpresses and the Minute clinics to pop up, how can we do that and not have access for patients in the name of care coordination and the patient-physician relationship?
Thank you, Carolyn.
You have a minute.
You've outed us. So the reality is, that is our patients standing on the tops of the rooftops saying, we want this. It's not, there's no perverse mind game that's going on that's, they're walking there like zombies to Walmart looking for care. They just, that's what they want from their health care. So, I mean, in my own department, we are extending our hours. That's a small change. We're trying to be there where our patients need us. We need to develop, in the spirit of capitalism, somehow, some way to coordinate care so that if they do get care somewhere else, it really truly is integrated care. So that our teams become, I love Justin's analogy, somebody said, never stepped outside their office. I mean, care is going to happen outside our office. We better figure out how to bring it to the team. And I think that is a very big challenge for us, to give people are used to consumerism that exists at their doorstep. And that would be a hard challenge, but I think we can do it. I do.
Well, I wish we could extend our hour. And I hope that the conversation goes beyond just this auditorium and out into your neighborhoods. Please join us next week for a program on sex, sin, and science, syphilis in America, with medical historian John Paris-Gondola and Dr. Rebecca Dillingham. Please thank Susan Okie, Sean Reed, and Justin.